And younger women fare worse. Their likelihood of dying the first year following a myocardial infarction is about twice that of younger men. So this is a disease that, yes, tends to affect older women. The data that I showed you is age-adjusted, but we have a huge problem with younger women, particularly with deaths following myocardial infarction. And women of color and of low socioeconomic status, no surprise, are disproportionately affected, up to 28% higher death rates, particularly for African American women. And I'll say a little bit more about that in just a minute. So how are we doing compared to the rest of the country? Well, here's a map of the death rates for the whole country. As you probably know, death rates are very high in the southeast, and in the south, for the first time ever, we have declining average survival compared to the previous generation. We have a terrible problem in the south and southeast. California overall better, but there are certain counties that have very high rates, particularly in southeastern California, and then two Central Valley counties, San Joaquin and Stanislaus counties, also have quite high rates of cardiovascular disease. This particularly didn't show up in color, but it's the next to the highest rate compared to national standards. So we are doing no better overall in terms of cardiovascular disease death rates than the southeast in many cases, particularly in certain counties located in the Central Valley and southeastern California. Now, if we break this down a little bit further and look at the age distribution in California, this is data from the California Department of Public Health. We can see that just like the rest of the country, there are indeed more deaths in women than men every year in the state, and that most of the deaths occur in older women, those over the age of 65. And in fact, the largest and growing group of mortality is in women over the age of 85. Now you might say, well, they're 85 years old. Well, that's true, and hopefully they've had a really wonderful life. But as you know, life expectancy is increasing for men and women. Women outlive men. And this is a time period where a lot of chronic disease is occurring and coalescing, which is partially contributing to the risk. But we can't forget about the older women, because that is where a huge percentage of the deaths are occurring, about half of the deaths in women. And that's a group where we have relatively less information. So we are victims in a way of our own success in terms of healthcare and health prevention and health promotion, but we want to make sure that we tune not just to women in general in terms of cardiovascular disease, but the younger women for different reasons and the older women for different reasons, given their higher mortality. Now here are now national mortality trends. So up to 2000, we had a relatively big disparity in total deaths between women and men. In other words, men were deriving relatively good benefit from all of our current interventions for reducing cardiovascular disease deaths. But women were not deriving similar benefit, and in fact the mortality trends were rising a little bit or remaining flat. Now, as you may be aware, a lot of national efforts have been taking place over the last 10 plus years, including the National Institute of Health, National Heart, Lung and Blood Institute Heart Rate campaign. I'm a spokesperson for that campaign and a West Coast partner, and the American Heart Association's Go Red for Women campaign, and many other efforts. And we think that because of that, in part because of that, mortality trends in women are now starting to decline, but note that they still remain higher than those for men. So there's still work to be done. And this is similar data for California, and I'm showing you age-adjusted data. showing that yes, in fact, for almost all ethnic groups, mortality trends are declining. But here now we can very, very clearly see that in African Americans we have the highest death rates. This is fairly recent data, 2008 data. And the Caucasian group is shown in the pale blue here. So ethnic groups, particularly African Americans, continue to have the highest mortality from this disease. How does Sacramento fare specifically, since we're here, and one of you is kind enough to send me this data? So here's the prevalence of chronic disease in terms of stroke, coronary artery disease, and hypertension compared to the rest of the state. And we actually fare a little bit worse than the rest of the state in terms of prevalence for cardiovascular disease, stroke, and hypertension. And we do have some counties that have high rates of death within the Northern California region that don't compare as seriously to those in the southeastern counties and some of the central counties, but still places in a relatively high death rate group. Now, you might by now be asking yourself, well, why is that? Why is it that we have disparities in terms of deaths? Why is it that heart disease is the leading killer of women? Why is it that death rates are higher? And what I'm going to show you next is a series of reasons. It's not by any means all inclusive, and you may think of additional ones, and in fact there are more. But one of the problems is that heart disease is still recognized by less than half of women. So the Heart Association has been conducting national polls, and the last was done a couple of years ago, and we started off with less than a quarter of all women in the country knowing that heart disease is the leading killer. Now we're to about half, 52, 53%. So we're doing better, but it's taken about 10 years to get there. So still, roughly half of the women don't know that it's the leading killer. So there's a tremendous role for just plain old education in terms of knowledge and awareness. Second, there is still the misperception that we're dealing with a man's disease. And we know that women are not small men. That's been well shown in terms of anatomy, physiology, genetics, etc. There are a huge, vast number of gender and sex-specific differences. And also, we know that over a third of women don't perceive themselves to be at risk. They really do believe that it is a man's disease, or it affects someone else, but not them. So we need to make a better connection to women. And even those that know about risk factors have poor knowledge about their own risk factors. And the Heart Association has a campaign on that. I'm sure many of you know about the campaign, and it's a focus of one of our educational efforts this year in our program. But women have, in general, poor knowledge of their own risk factors. What is their blood sugar? What is their cholesterol? What is their blood pressure? And what are normal ranges for them? And furthermore, they fail to link risk factors to coronary artery disease. So they may know, for example, that obesity is not good for your health, but they may not know that obesity is linked to cardiovascular disease mortality. And they may know that hypertension is a risk factor for stroke, but they may not link hypertension as a risk factor for cardiovascular disease. So there's room for improvement there. And we also, as health professionals, have some role to play in this. About a quarter of women say that their health providers don't emphasize cardiovascular disease risk control knowledge in their physician and health professional encounters. And there's also concerns about lack of health provider emphasis on how to make the lifestyle changes. So their advice may be you need to do X and such, but that may not be linked to appropriate referrals to allied health professionals to help patients make those changes or to resources to help them make the changes. And we know that lifestyle changes are very effective. They're called therapeutic lifestyle changes for a reason, because they work. But we need to do a better job at teaching patients what to do and how to do them. There are additional barriers that relate to delay in diagnosis and treatment and overall less aggressive management for women. There's a huge body of literature documenting this. And an underestimate of risk, even by the current risk assessment measures, which I'm going to discuss next. And part of this may relate to the fact that women present differently, and their management needs to differ, and that they're older and have more comorbidities at the time of diagnosis. And this is something that's very important for us to recognize, that women are going to come to us in general at a more advanced stage of disease and with more comorbid conditions. And there are a lot of unknowns still. I mentioned earlier that we have limited data on the largest growing group of deaf and of women, which are those over 80. We really have, I think, just started to scratch the surface on the impact of culture, ethnicity, race. What are the important factors there? Gender differences in pharmacologic effect have been studied, and we know, for example, that drugs like ACE inhibitors have a higher incidence of cough as a side effect in women, which limits their use sometimes. Timing of initiation of menopausal hormone therapy, still a big question mark on ongoing studies right now. The KEEPS study will help answer the question raised by the Women's Health Initiative study, which is, do younger, more recently postmenopausal women benefit in terms of cardiac risk protection? We know that older women started later after menopause do not, and in fact have harm. But should younger women be started? We don't know the answer to that yet, and many, many other issues. So we also have disparities in healthcare for women due to this whole list of barriers that I listed. Yet at the same time, we know that most of heart disease is preventable. Joanne Mason at Harvard has published model data. Their most recent estimate is that 90% of all cardiovascular disease is preventable. Her prior model was 80, so now it's been upped. So now we know that essentially cardiovascular disease is a preventable disease, yet it's under-recognized as a leading killer, as I said. This just came out from the Department of Health and Human Services. One of the findings of our national project with them looking at model women heart centers was that their women, even if they're taught the importance to call 911, will not do it. There's a resistance there. And so they wanted us to look at this more. And what we found is that only about half of women would call 911 if they were having symptoms of a heart attack after being taught what the symptoms are. Do you guess that they would be more likely to call 911 for a male having those same symptoms? Yes, and in fact they would. So there's something going on there about, this doesn't pertain to me, and other factors that we need to better understand. We also know that only 8% of primary care physicians and less than 20% of cardiologists recognize that there's a greater death toll for women from cardiovascular disease. So this is a problem. It's a huge problem. They may know that heart disease is the leading killer for women, we hope, but they may not recognize that more women are dying of heart disease. So again, I think all of these factors are important in terms of the sense of urgency. And so I think that there should not be a surprise that cardiovascular disease in women remains underdiagnosed. The symptoms are more subtle, and you may have heard about this. They're less severe, they're less typical. In fact, what's typical is atypical symptoms. And other symptoms, for example, dizziness, exertional shortness of breath, lightheadedness, reduction in functional capacity for a month prior to myocardial infarction. All of these may predominate as opposed to chest disease. And if women experience atypical symptoms, they're often not referred for further studies. The Women's Ischemia Syndrome Evaluation explanation for why there's a higher mortality per the figures that I showed you earlier. So it's a very, very complex issue. What I want to do is talk about the new guidelines for heart disease prevention in women next, because what they have tried to do is take all of this information and put it in a context of very practical advice and recommendations for health professionals. And so these guidelines were first issued about 10 years ago. They've been revised about every 2 to 3 years as new data and evidence is available. The last issuance was last year, March of last year, published in Circulation. Lori Mosca at Columbia was the lead author. And they were an update from the previous version, which was published in 2007. Guidelines, as you know, are not dogma. They just provide a framework for us to approach patients. These guidelines were developed from evidence, clinical evidence, based on research, studies in women where those were available, those in men or mixed populations where data was not available, but it was thought by the task force that data could be extrapolated. They were based on clinical practice, what do you do, what do you do, what do you do? And finally on consensus of the expert panel. These are the 3 elements that go into the development of guidelines: data, clinical practice, and consensus. And so what I'm going to go through with you are the guidelines. Now, why were the previous guidelines not good and the ones before that not good, and why do the guidelines need to keep becoming updated? Well, these guidelines were updated because there was a recognition that the major risk factors are not sufficient to appropriately risk categorize women. And we need to consider other risk factors, including family history, subclinical disease, poor exercise capacity, not the inability to exercise more than 2 minutes on a treadmill is a high-risk marker for women, and unhealthy lifestyles, because we know that therapeutic lifestyles work. In addition, the prior risk stratification relied almost exclusively on the Framingham risk score, and that was felt to provide too narrow a focus because Framingham gives a 10-year event risk rate, whereas what we need to be informing women about is their longer-term lifetime risk. Too many women were lulling themselves into a sense, and physicians, into a sense of complacency, thinking that their 10-year risk was, oh, it's not so bad, it's relatively low, when in fact the lifetime risk was much higher. And in addition, additional factors like family history and pregnancy-associated conditions needed to be included, and that the prior categorization of a low-risk woman really was not sufficient to ensure low risk. So what the new guidelines now emphasize is a woman's global risk, lifetime risk for cardiovascular disease, and that it's very high. It's about 50%. So of all the women in this room, half of us will die from cardiovascular disease. And so there was a new risk categorization for classifying women, which I'm going to go over. And previously, the guidelines were termed effectiveness-based guidelines, but the term was changed to efficacy because there was a concern that practitioners were thinking that this was too theoretical and too research-based, and the task force wanted to make sure that there was an understanding that this is what works in clinical practice. In addition, there were revisions regarding aspirin, hormone therapy, folate, and antioxidants, which I will review, and new very practical tips for lifestyle therapists. What do we need? What do we mean about heart-healthy lifestyles? What do we mean about appropriate physical activity? And I will review those with you. Let me start with this concept of global cardiovascular risk. What does that mean? Well, previously, as I stated, the emphasis was on this tier, the upper tier, the major cardiovascular risk factors. And we can't forget about those. But women live in a context of their genetics and their environment, which includes the hormonal environment, their social environment, cultural environment, etc. And this whole conglomerate, if unattended to, can lead to subclinical disease. What does that mean? Well, that means that disease is present in the vessels, but the patient is not symptomatic, so it's subclinical, but it's still there. And this is now second tier, going from major risk factors to having disease. Markers include left ventricular hypertrophy, coronary calcium, for example, carotid stenosis, inflammation, like C-reactive protein, that's a marker of subclinical disease, and endothelial dysfunction, abnormalities in the function of blood vessels, which can be there with or without obstructive disease. And then this whole cascade will, unfortunately, in way too many of our patients, lead to the clinical disease that we end up treating: heart attack, stroke, peripheral vascular disease, heart failure, etc. So global risk really looks at this whole entire composite and how can we keep patients from progressing down this ladder. So what does that mean in terms of the vessel wall? So I'm a cardiologist, I'm a vascular biologist and scientist, and I study the blood vessel wall and how it's modified by a number of things, including hormones. Now, I hope you can see here, this is an image of an aorta, pathologic specimen of an aorta. You all finished your lunch. This is a good time for me to be showing you these slides. Hopefully it was heart healthy. Can you see these streaks? I don't know if they project well, yes? Oh, yeah. These are fatty streaks. They're subendothelial deposits of fat. They're lipid-laden monocytes. They're monocytes that go into the vessel wall and become macrophages, which take up lipids and create these streakings of fat in the subendothelium. We all have these. Toddlers have these. 2-year-old toddlers have them. Normally, lipids come into the vessel wall and they efflux and go back out to the circulation. However, with risk factors and abnormalities to the endothelium, lipids can come in and stick and start to develop the atherosclerotic plaque. Now, some people think that it's on top of the blood vessel wall. It's kind of, attached to it, and if we could just get rid of it. But you really do need to understand that it is part of the vessel wall. Here is a very fatty, fibrofatty plaque that's eccentric. It's only in the lower portion of the vessel. And what does it look like to you? Kind of buttery, cheesy. It looks very fatty, doesn't it? How did this get there? How did it get there? I like to say the person ate it. The patients ate their plaque, right? Because to a large extent, what we're talking about is a preventable disease that's really sort of provoked by modifiable risk factors and heart healthy or unheart healthy lifestyles. So for too many of our patients, these plaques develop as a consequence of unhealthy lifestyles and diet. Now, if you were to do a heart catheterization on this woman, what would it show? What would you expect it to show? A clean vessel, exactly. It would show a normal coronary artery, right? Because a heart cath is a luminogram, in essence. We put contrast in the vessels, we do an image. This would look perfectly normal, and the plaque is eccentric, and it would look normal, but the person clearly has significant disease. Now, if this is allowed to progress, then we end up with events like a myocardial infarction, which is a ruptured or fissured or eroded plaque. And here's a pathologic specimen of a woman who had a large MI. You can see, I hope the blue here, which is a thrombus, further occluding this vessel, and really all that's available for blood flow is just not really present there, which was not compatible with blood. So what we're trying to do with heart disease prevention is prevent the progression of this disease cascade. So if you think about it in terms of trying to attain vascular health, it may help to give you another context for this. So let's move and talk now about the new risk categories. Why did they have to be redefined? So the risk categories currently are 3. You are either in the high risk, in the at risk that got markedly expanded, or in the ideal risk that got markedly shrunken. That category got very, very small. So the simplest to discuss is high risk. So who would be a high risk woman? A A high-risk woman would be any woman that has one or more of these high-risk states. Well, what are they? They already have disease. So they have clinically manifest coronary heart disease, stroke, peripheral vascular disease, aneurysms, vascular disease, diabetes. Why is that in there? Diabetes. It's a heart disease risk equivalent, exactly. So we treat all diabetics as if they already had established disease. All diabetics must be managed just like all high-risk individuals. CKD or end-stage renal disease, no creatinine provided. Why is that in there? Chronic kidney disease or end-stage renal disease. Sorry, I need to watch my abbreviation. Well, think about what leads to that. Diabetes, hypertension, the two leading causes. It's because really these two are vascular diseases. Their complications are vascular. And then a 10-year Framingham risk score greater than 10%. Previously it was greater than 20%, and that markup reduced to greater than 10%. Now what about the at-risk women? Which women are in this category? Well, any woman that has one or more of any of the major risk factors. That was that top tier I showed you in the global risk score. So obviously smokers, individuals who have high cholesterol, etc. However, if you don't eat heart healthy, you're also in the at-risk category. And if you don't exercise to goals, you're also in the at-risk category. If you obviously have premature cardiovascular disease, defined this way, and then if you're hyperlipidemic or hypertensive, or on therapy. A lot of my patients think that because they're on treatment that they no longer have that condition, or they no longer have the risk factor. What we've done is mitigated and optimized the risk from that condition, but the condition still remains a risk factor. Now, this category, as I mentioned earlier, got markedly expanded. So the at-risk women are not just the ones I just went over, but now we have any woman with subclinical atherosclerosis, so any woman that has coronary calcium, any woman that has a chest x-ray and has aortic valve calcification. I always look for these on all imaging studies because they're clues. Oftentimes you do the Framingham risk calculator, you think they're at ideal risk, but in fact they're not. If they have LVH, left ventricular hypertrophy, C-reactive protein is elevated, all of those are subclinical disease markers. I've already mentioned poor exercise capacity or abnormal heart rate recovery. What does that mean? Abnormal heart rate recovery. Here you are, you've exercised on your treadmill, and after, your heart rate recovery is not normal. What does that mean? Your heart still thinks that you're exercising, but you stopped 10 minutes ago. That's basically a marker of physical deconditioning, of being out of shape. So that places a woman in the at-risk category. We know that many of the autoimmune collagen vascular diseases have predominance in women, including lupus, rheumatoid arthritis, Sjogren's, etc. All of those now, we automatically place the woman in the at-risk category because they're linked by inflammation. And now we've added the pregnancy-associated metabolic disorders. Previously, women thought incorrectly that if they had gestational diabetes or hypertension, for example, that it was just a pregnancy-associated problem. We know now that it's not. These women have significantly higher risks of developing these conditions within 10 years, and their offspring, having essentially grown up in this abnormal intrauterine environment, also have higher risk for cardiovascular disease later on. So now it's recommended that when you take a history, you ask questions about pregnancy-associated disorders, and it's thought that this is, in essence, a woman's first child. And then the metabolic syndrome. The metabolic syndrome is a clustering of risk factors. 3 applied following lead to increased cardiovascular events, about 15% higher risk. The definitions depend on whether you're male or female, so I'm going to go over those for women. Hypertension with blood pressure over 130/85, or being on treatment. High triglycerides over 150. A lot of patients, see their primary doctors. The primary doctor says your triglycerides are 200, 250, they're a little high. They're very high. Those are high levels. They need to be controlled under 150. HDL in women should be over 50, so under 50, that's a risk factor. Elevated glucose, right now their recommendations are for glucose under 100. And central obesity, waist circumference more than 35 for women. What would the central obesity measure be for men? 40 inches, right? And what about the LDL cut point? 40 for men under 40. Yeah. So those are the two distinguishers for men and women. So the metabolic syndrome now, which is underdiagnosed, we oftentimes see the risk factors, but we don't cluster them together. We don't see the clustering. Needs to be included as in the at-risk category. So that leaves us with, okay, well, who is now in ideal risk? So in order to be at ideal cardiovascular risk, per new guidelines, a woman must have a Framingham global risk of under 10%. Before it was under 20, so that's a new cut point. But that's not enough. And she must have a healthy lifestyle, diet, and exercise to guidelines, which is 150 minutes a week of moderate intensity, or 75 minutes a week of vigorous intensity, or ideally a combination of both. That's minimum. And that's not enough. She also must have no risk factors. So cholesterol under 200, blood pressure under 123, glucose under 100, BMI under 25, and not be a smoker. So low Framingham risk, no risk factors, and heart healthy lifestyle. So I won't, this is a small group, I won't ask you to raise your hands, but oftentimes, you can if you're proud of yourself, but then of course we'll all just boo at you. But oftentimes in our large CME conference, I start by asking, before I go to the risk categories, how many of you think that you're an ideal risk? A whole bunch of hands go up. And then I go through the categories and I say, okay, now how many of you? And maybe just 5, just a few. It just goes to show that it really does take quite a bit of effort to think about your heart health and to maintain that. So notice that you still need to determine the Framingham risk score though. So you need that for categorizing women in the high-risk category if they don't have established disease. You also need it for making sure that you are identifying a low-risk woman who may have heart healthy lifestyle. So that can be found online. The URL is there. And this is just an example. It's been verified for 5 key risk factors: age, cholesterol, smoking, systolic blood pressure, and HDL. You add up all the points, come up with a percentage. So let's say that if there's a score of 20 for these risk factors, then the risk score would be 11%, which would place the woman in which risk category? In the high-risk category. Remember that final marker there was Framingham risk score greater than 10%. So 11% would place the woman in the high-risk category. And you can see this woman is in her mid-40s. Her cholesterol is, low 200s. She smokes. Her blood pressure is in the pre-hypertensive range, and because she's a smoker, her HDL is low. That's all it takes. That's all it takes. So you can see how easily, now if she did not smoke, 7 points would be subtracted, and she would then go to the low risk category. Potential. Now, why do we care? Why do we want to focus on making individuals, trying to help them attain ideal cardiovascular risk? Maybe it's just, an unattainable kind of ideal. That's all it is. Well, we know that those in the ideal risk category live longer. So that's good. Most of us want to live longer if we can live healthy. There are dramatic reductions in risk for cardiovascular events, 7-fold short-term, 20-fold long-term. Those are significant. And the Nurses' Health Study last year published a very interesting set of findings showing that there's a 92% reduction in sudden cardiac death, older ages for those in the elderly risk. And we save money. So it's a win-win. It's a win. Okay, I want to move now and talk about treatment recommendations, and I'll just go through them quickly. They are linked to the risk categories. And the treatment recommendations are really in 3 levels. Lifestyle recommendations, which are a priority, that's what we really should be focusing on. Then attacking each of the major individual risk factors that a woman may have, utilizing preventive drug therapy as needed to accomplish that. So lifestyle interventions are recommended for all women. They include, obviously, no smoking, being physically active, heart healthy diet, including fruits, vegetables, grains, low sodium, low fat, low alcohol, low total calories. And I'll go over this in more detail. And then having an appropriate BMI defined as less than 24.9 for women. For high-risk women, we need to implement all of these, plus cardiac rehabilitation for any woman that's had an acute coronary syndrome, a myocardial infarction, a stroke, etc. So attuned to psychosocial factors, particularly depression, which we know is a risk factor for cardiovascular disease in women and is associated with higher events and death rate following the diagnosis in women, and there's a higher prevalence of depression in women and men. And then using omega-3 fish oil, which I put as a lifestyle because many patients think of this as kind of a healthy, over-the-counter supplement and don't think of it so much as medication, although of course it is medication. Now, what about specific diets? So the guidelines are very nitty-gritty, and this is what they recommend